Good morning. This is Babak, Larian, and we are doing a session of Facebook Live Q&A, answering any questions you may have in regards to salivary gland or parotid tumors, and addressing any concern during these difficult times where people's access to healthcare is more minimal, and so hopefully I can be a source of some sort of access that will be helpful and meaningful to everyone. Anyways, let me go ahead and start this morning's session. There's a question from Letitia Poole about, the question is, what causes mucoepidermoid carcinoma? Can this cancer come back? I got 1 millimeter clear margins after surgery. Is this good? Can scar tissue form a lump where the parotid gland used to be? Thank you. All right, Letitia. Very good questions. Let me first actually turn you around and show you, in terms of the cancers and tumors in the parotid, 20% are cancerous and 80% are benign. Majority of tumors that happen in the salivary glands happen in the parotid gland. So 80% of the tumors in the salivary glands happen in the parotid gland. And the reasoning for that is probably the quality of tissue that's in the parotid. This is the parotid gland, right? This is the submandibular glands, sublingual glands, and there are 200 tiny little glands like the little bumps on the back of the lip that are salivary glands. This gland, the parotid, is the largest, so real estate alone makes part of the reason why it gets majority of the tumors in it, but probably the genetic makeup of this gland is such that it predisposes to tumor development as well, more so than the other glands. Now, incidence of parotid tumors is not very high, or salivary gland tumors, but they happen most commonly in the parotid. There are 15 types of benign tumors that happen in the salivary glands, and the World Health Organization has a classification for it, majority of which is pleomorphic adenoma, right? And then there are 20, probably a little bit more, cancerous tumors in the parotid gland, cancers from the lining of the parotid, 20 of them, right? And you can see mucoepidermoid is the most common type of cancer in the parotid and the salivary glands altogether, followed by adenocystic, adenocarcinoma, malignant mass, actinic cell, squamous cell, and so on, and multiple other types. There are, so when you look at it overall, pleomorphic adenoma is the most common type of tumor that happens in the salivary glands as a whole, right? So let me see if you have anything on mucoepidermoid. Well, I just have to say, tumors can be of varying sizes. They can be very small, like this one here, or larger and massive, right? And all that is meaningful when you have a mucoepidermoid carcinoma, because the size of the tumor matters in terms of how much of a margin you need to get. So when you have a tumor that's, let's say, this big, it's possible that this tumor has tiny little legs that extend outside of the gland that are microscopic, right? And so when we remove cancers, we usually try to get as much of a margin as we can, right? So we usually try to get 1 centimeter, 1.5 centimeter, based on the aggressiveness of the tumor, margin around it. In the parotid gland, that's tempered by the fact that you have the facial nerve. So the facial nerve comes out of the brain into the skull bones and does one turn and then another turn in the ear and then enters the parotid. It comes out through a opening in the skull, right? comes out of that opening there, enters the gland, and gives you a branch, a lower branch and an upper branch. And the lower branch goes to the lower lip, upper branch goes to the upper lip, smile, eye, and forehead muscles. Now, if this here is more than 1 centimeter away, then your margins are good, 1 centimeter margin. But if your nerve, so let's get rid of all this. But if your nerve is coming out and immediately passes by the tumor, then you can get 1 centimeter margins here, 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 and then when you get to that, you're going to be close. And so, obviously, it's the location relationship to the nerve matters. The other thing that matters is what type of cancer it is. Mucoepidermoid carcinoma comes in 3 flavors. It comes in a high-grade version, which is very aggressive and needs to be removed quickly with wide margins, almost always need radiation treatment. There's intermediate grade that's at the halfway in between, so you have to kind of assess how fast it's growing, what it's doing, how much tissue is around it, check some of the markers inside of it to assess aggressiveness, to see if it's getting into the blood vessels or lymphatic vessels or eroding through any kind of nerve. Those tell you what the character of this tumor is and how aggressive it is. And then there's low grade, and the low grade tumors tend to be less aggressive, tend to spread less to the lymph nodes and other parts of the body. So if you had a low grade mucoepidermoid carcinoma, a 1 millimeter clear margin is probably okay, right? But if you have a high grade tumor, a 1 millimeter margin is not adequate, right? Because the reason for it is, let me explain. Again, let's clear this up. So if they got a 1 millimeter margin there and more so on the other side, so this here is 1 millimeter, and if you imagine they're microscopic legs. Now, these legs are not as big as this, so if you magnify to the tumors 1,000 times, so that this is the edge of the tumor, right here. You're magnifying this part. Let me do it in blue. You're magnifying this blue part. And that little bit of tumor inside is this big. You magnified it, right? And what was taken out is this. So this distance is 1 millimeter, Letitia, right? What pathologists do is they slice up the specimen like this and look at it under the microscope, right? So the specimen is cut, and then they put that cut under the microscope and look at it, right? If you have a leg that comes up like this and eats through that edge, but it's in between the cuts, they won't see it. If it is right at the cut, they'll see it, right? So this one they would see, and this one they would miss. And so when we have close margins like that, you will not have certainty that you have a true negative margin if you were to look at it. That's why we need a larger margin for the more aggressive cancers. So the high-grade mucoep, if you have a high-grade or intermediate mucoep, a 1 millimeter margin is not adequate. If you have a low-grade mucoep that doesn't have any vascular invasion, any invasion into the lymphatic tissue or any branch of the nerves, then a 1 millimeter margin may be enough. It does require that you have a heightened alertness to it and be regularly followed by a doctor to monitor it. And then, so what causes mucoepidermoid? The only thing that we know that causes it is radiation exposure. So if someone has lymphoma as a child in their neck and they get radiated 20 years later, 10 years later, they can develop a mucoepidermoid carcinoma in the salivary glands. That's the only thing we know. Obviously, that's majority of cases do not have that history, so there must be more to it. Can this cancer come back? Again, it has to do with the grade of it. If it's low grade, very unlikely for it to come back if you have a negative margin, even a 1 millimeter negative margin. If it's intermediate or high grade, the chance of it coming back is more if the margins are not widely clear, meaning that if you have a 1 centimeter margin or 1.5 centimeter margin in all sites, and there's no tumor coming to that edge, and there's no invasion of the lymphatics, the blood vessels, nerves, and there are lymph nodes in the neck, which on a high-grade tumor, they usually take out the lymph nodes in the neck, and the lymph nodes don't have any cancer in them, then the chance of recurrence is low. If any of those things that I just mentioned are positive, then the chance of the tumor coming is higher. That's why we use radiation to try to minimize that chance. So radiation treatment after surgery. And so I think you need more information to make an assessment. Now, you also asked, can scar tissue form a lump where the parotid gland used to be? Absolutely. Any area that you operate on here. So when you do a parotidectomy, you essentially are removing that tumor, right? So when you do a parotidectomy, so when they remove the parotid tumor, they also remove a portion of the parotid gland, right? Any area that they operated on, right, can form a scar. Just like when you get a cut in your arm, and when it heals, it can be a thicker scar. Sometimes it's a nice thin line and it's not even visible, and sometimes you get a big thick scar, right? And so it can be. And so you can have a thick scar formation that looks like a lump here. So generally speaking, what I recommend to my cancer patients is that they do a scan, sometime after they've had surgery, and based on the patient, you can decide if it's, based on the aggressiveness of the tumor, you can decide if that's 3 months after radiation, or 6 or so, right? When it's a less aggressive tumor, you can probably do it either at 6 months or 1 year and use that as a baseline. And then every year following that, you get a scan and compare it. And if you have a lump that was present at 3 months after surgery, and you check it a year later and the lump is the same size and hasn't changed, then you can surmise that was a scar formation rather than a tumor that has come back. Because if it was a tumor that had come back, it would have grown, right? So I think that's the reasoning, and I think you just need to make sure you have a good relationship with the surgeon that did the surgery for you, because the ear, nose, and throat surgeons that do this are the ones who tend to follow the patients and manage and monitor them, and that's the key. Having a good relationship with that particular doctor that not only explains everything to you, but is diligent and staying on top of it is key. And that's the most important advice I could give you, okay? And now, mucoepidermoids that have spread to other parts, that have eaten through the capsule of the parotid gland and are more aggressive, obviously need further treatment. And radiation treatment is definitely needed for those particular types of cancers. Sometimes we even, if the tumor is even more aggressive and it's showing signs like if it has spread to the lymph nodes, but in the lymph nodes it's spread outside of the capsule or the covering of the lymph node, which tells you genetically that particular cancer is very aggressive, sometimes we even add chemotherapy or immunotherapy to the treatment, to the radiation, which will make the radiation even more effective and the chance of cure significantly more. And so, again, all this information is important in figuring out how much needs to be done, how diligently and how often you need to do scans and you need to see your physician, and what kind of other treatment, radiation or chemotherapy or combination you would need to treat the mucoepidermoid, okay? It's hard when you have this diagnosis. When you hear the word cancer, it already is hard, right? I just really urge you to understand the aggressiveness of your cancer so that your level of alertness and is appropriate for that. So for example, the cancers come in different varieties, right? So to use skin cancers, melanoma, a skin cancer that happens usually in one of the moles, or arrives from the moles, or derives from the layer of cells that make the pigment of the coloring of your skin, and it's the same pigment that gets bronzed when you're in the sun, that pigment, and that's when you turn bronze, that's your body trying to protect you against the damages of the sun. Even though it's a nice, pleasant color, it's just an indication of damage. Anyways, so melanoma arises from those cells, and is an exceedingly aggressive cancer. If it's more than a certain millimeters of thickness, or if it has spread to the lymph nodes, then the chance of it having spread to all the rest of the body is very high. So if you were to get a scale of 0 to 100 and say a melanoma is 100, there are some cancers that are even more aggressive than melanomas. Anaplastic cancer of the thyroid, for example, which there's absolutely no treatment for, right? But let's say that melanoma is 100. Basal cell carcinoma on that scale of 1 to 100 is like a 2 or a 3, because it can grow very slowly. The chance of spread is exceedingly low. Doing a small surgery where you take minimal margins around it is more than adequate to treat it. And so, if you have the same size, if you have a 2 millimeter, let's say a 1/4 inch basal cell, you can leave it for a while and be okay. It doesn't grow, may grow slowly, but it won't spread. But melanoma, you have to go take them to the operating room pretty much immediately, right? Because you don't want it to grow any deeper or more and spread to other parts. And so the acuity of the two are entirely different. And that's why looking at the aggressiveness of your tumor is meaningful. So if your mucoepidermoid is low grade, it's towards the lower side of the scale. It's not a 1 or a 2, it's the 10, 15, 20, where high grade is 70, right, in terms of aggressiveness. And so once you know where you stand on that, then you know how much you need to be on top of it. Jamie Johnson is asking, what are the symptoms of infection after parotid surgery? Usually it's swelling of the area, redness, and increased discomfort or tenderness. So if your skin is swollen all of a sudden, so over a day or so, it swells up, it becomes red, and tender to the touch, and when you push on it, the redness goes away, and then it immediately comes back, it blushes away, then those are signs that you definitely have an infection. If you've had surgery 4 or 5 days ago, and then all of a sudden the area becomes more painful, you have to get concerned that probably there is an infection starting, even if the skin is not red. So any of those signs happen, you definitely have to talk to your doctor and try to figure out as quickly as possible what's going on. After surgery, the complications that can happen. Once the surgery's done, the facial nerve is safe and functioning properly, and you come out and everything works out in that way. In the next few days, the things that can go wrong is you can get bleeding under the skin, a hematoma can occur, so again, the face would swell up. That's not very common because the parotid gland doesn't have big blood vessels, and if your surgeon is very meticulous and controls all the tiny blood vessels, the chance of hematoma is very low, although it can occur, but it's significantly less than 1%. Infections happen. Most of the time the infection happens because when you cut the parotid, here, let me show you. So when you remove, let's say this is a superficial parotid, which means all the parotid superficial to the nerve is removed, right? This cut edge of the parotid here, right? These are all exposed parotid surfaces, right? Every time you eat, they produce saliva, right? So saliva is coming out of these areas. And because they're not going into the ducts, they can go into the tissue under the skin, right? Which is why some people use drains, or some people use pressure dressings, or a combination depending on how much surgery has been done. And by putting pressure dressing on there, right? By putting a pressure dressing, which is a ball of gauze and a wrap that pushes on it, you collapse the space and don't allow there to be any distance between the cut surface of the parotid and the skin. They're on top of each other and collapse onto each other. So saliva doesn't accumulate in there. Because when saliva does accumulate in there, which happens maybe 3% of the time, that stagnant saliva is the perfect solution, perfect medium for an infection to grow. It's like a petri dish, full of water, dark, damp, and full of proteins and nutritious stuff that a bacteria would like. So accumulation of saliva is what predisposes people to having an infection in that area. So that's why pressure dressings are important, drains are important, whichever technique your surgeon particularly likes to use to manage it, right? And I say the most common complication after surgery is saliva accumulation under the skin. Not every time saliva accumulates it gets infected, it just increases the chance. When it does accumulate, what we have to do is put a needle in there and withdraw the saliva out so it does not under the skin and stagnant, and then put a pressure dressing on so that you collapse the space. So that would be my advice. So Jamie, if you're feeling like you have fluid collecting under the skin, when you feel it, it feels like fluid pushes away. So when you feel it, you get movement of fluid. Then you should go to your doctor and have them put a needle in it and aspirate it. If there's tenderness and discomfort and redness of the skin, then you definitely need to start antibiotics as well. And if you're already on antibiotics, you may have to change your antibiotics, but let your doctor know so that they can manage that for you, all right? Hopefully that's helpful for all of you, both Letitia and Jamie. Hope you guys have a wonderful day. Best of luck. Please take good care of yourself and stay safe. Talk to you next month.